Start. Good morning, everyone. Thank you, AIOS, for giving me this opportunity. So we all know. Excuse me. Okay. As we all know that watering is the main presenting complaint in any plastic OPD, and external DCR is the treatment of choice. But what brings distress to both patient and surgeon is a post-op epiphora. Failure rate of endonasal DCR being slightly higher than the external DCR, which brings us to the purpose of our study, which was to evaluate outcome of repeat external DCR in terms of anatomical and functional patency in failed prior DCR and investigate causes of the failure of primary surgery. It was a retrospective, non-randomized interventional case series. Out of 270 patients who underwent DCR, 28 were included who had a history of prior DCR. So inclusion criteria was age more than 18 years, minimum 3 months of follow-up, and history of previous lacrimal sac surgery. Also the patient who consented, and all the patients with history of trauma and suspected neoplasia were excluded from the study. So a brief discussion about external DCR, starting with the meticulous sac dissection, followed by ostium formation, taking care of to maintain the standard boundaries mentioned in the literature, followed by raising the nasal mucosal flap and its taut anastomosis, because the saggy one will sag down and eventually obliterate the ostium, leading to the failure. So talking about the results, there was slight female preponderance. Epiphora was the main presenting complaint, and mean age of presentation was 48.6 years, and mean group was 41 to 50 years. Mean duration between previous surgery and recurrence of symptom was higher in external DCR, 18 months, and endonasal DCR was 10 months. Other associated conditions that could lead to epiphora that were included in our case were MGD in the highest number of patients, followed by lid laxity, punctal stenosis, and eversion. So maximum patients, 61% had history of endonasal DCR previously, followed by external DCR. Then there was a group of patients that had underwent multiple surgeries previously, like twice under endonasal DCR and once endonasal and once external DCR. What we found intraoperatively as the main cause of failure was inadequate ostium, followed by complete obliteration of sac mucosa, higher lacrimal sac opening, and fibrosed sac. What we did intraoperatively was a meticulous dissection to save as much as possible remaining nasal mucosa and sac wall, and only anterior flap was sutured to the mucosa. Silicone tube was inserted in all the case and kept in situ for 3 months, and application of mitomycin C 0.04% for 30 seconds. So at a mean follow-up of 16 months, all patients had 100% patency anatomically, and no functional epiphora was seen. All patients has cosmetically acceptable scar. So discussing this patient case report here, this was a case of failed endonasal DCR done 2 years back. When patient came to us, she has a slight bluish cystic lesion in the inferior fornix extending up to the lacrimal sac region. A CT scan was requested, and extracorneal tissue was seen at the inferior aspect of the medial canthus. Intraoperatively, that cyst was involving lacrimal sac. It was resected, and even DCR was done with 100% anatomical patency. In this case was failed endonasal DCR done 1 year back. On nasal endoscopy, there was mucosal synechia. Synechiolisis was done, followed by external DCR, silicone tube, and MMC, 100% patency at 6 months. So we compared our study with the similar other studies, and what was specific in our study that we used mitomycin C and silicone tube in all our patients and not just a few specific patients, and we achieved 100% result. So it's very challenging to plan a failed DCR. However, with use of silicone tube and MMC, it gives excellent surgical outcome, and it's equally valuable in failed cases. Thank you.
So what is the most important surgical step for the best outcome in DCR surgery? If you want to prevent the failure of DCR.
Ma'am, most common
most important surgical step I am asking.
Ma'am, ostium formation.
Yes. Anything else you want to add to this? Ostium formation means what?
Like adequate size of ostium, like it should follow the standard guideline that has been mentioned in the literature, like 2 mm superior margin 2 mm above medial canthus, inferior up to NLDO, then anterior up to the sac and bony junction and posterior lip. So we start with paprecia itself.
All right.
Approximately 15 cross 15 size.
So it's both the size as well as the
Yes.
location.
Yeah.
If it's high up, then it can again create
Yes.
problem. And what do you call that syndrome?
Sump syndrome.
Excellent.
Good presentation. How did you fix your silicone tube?
Ma'am, we didn't specifically fix it. We just passed it and put multiple knots, around 10 knots, and left it there, and it was there in situ.
No, fixed in the nose or?
However, it can be stitched to the nose. It can be done, yeah, but we didn't do it.
Did you use the mitomycin or what stage of surgery you use mitomycin?
Sir, after anastomosis.
Okay. You want to give any flush with the mitomycin?
Sir, 10 cc saline.
Okay, what is the role
Thrice.
of giving a mitomycin like an
So
irrigation?
antifibrolysis. So it as the cases were already a case of failed DCR, so there was, as I mentioned, there was fibrosed sac and lot of fibrosis intraoperatively was seen. So that was also that also leads to the failure. So to minimize that failure and minimize further fibrosis and closure, we used it.
You have presented so many number of patients, but does any of the patient had history of trauma?
No, sir. We excluded trauma and miniblastic cases. Thank you, sir.
Any intraoperative difficulty you encountered?
Ma'am, intraoperatively, we found mostly the cause of failure was bony ostium itself. In one patient that had one failed indonasal and failed external DCR, we couldn't find there was adequate mucosa, nasal mucosa. In that patient, we sutured the flap with periosteum. And periosteum and orbicularis, and it gave it was patent. Thank you.
Okay, thank you.